And I'm so happy to welcome Jen Pettis from the Gerontological Society of America. So thank you.
Thanks so much, Laura. And I just want to make sure you're seeing my one single big slide.
Yes, exploring a new resource
Yep.
for dementia. Yep.
Perfect. All right, well, welcome. As Laura said, my name is Jen Pettis, and by background, I'm a nurse. And I need to tell you that my life's work has been in caring for older adults, and specifically in long-term care has been my love and my passion. What you won't ever hear if you or see if you read my bio or look at my CV is that I have any expertise in working with individuals with intellectual or developmental disabilities. What I do have is a bunch of friends who motivated me to work on this project, who do have that expertise, and we were blessed to work with those individuals to develop this resource that I'm going to share with you. And I am really excited to share that this resource actually has a lot of roots in Ohio. We worked with a couple of organizations in Ohio. We worked with the Ohio Council for Cognitive Health and the Ohio Association for County Boards of Developmental Disability as some of our experts on this. So we really do have, and this was certainly debuted in Ohio. So I'm thrilled at the interest of this in your state. And I hope you guys all realize there in Ohio that you do really good stuff around brain health. Ohio really does some amazing state and local county collaborations, and it's really, really exciting to see how wonderful Ohio addresses dementia and care for brain health care in general. It's really pretty cool. So congratulations on that. So actually, before we start, I just want to tell you a moment about Gerontological Society of America, or GSA. We are the oldest and largest professional society that's dedicated to the study of aging across the lifespan. So this year, GSA turns 80 years old, or maybe it's next year. I think it's next year. We will be an 80-year-old organization and really started kind of parallel with the National Institutes on Aging. So GSA is really a long history, and our mission is meaningful lives as we age. And it's really exciting that we have about 26 different disciplines in our membership. So when we look at aging or look at an older adult, we don't just think about the medical care. We don't just think about the social worker care. We think about transportation and human-animal interaction and biological research and nutrition and all of those other things that circle around an older adult. So it really makes what we get to do super fun. And this new toolkit really grew out of a much larger initiative that we have that I'll discuss with you a bit. Just to kind of level set a little bit, I want to compare signs of Alzheimer's or dementia to normal aging to start, and then talk about ways to promote brain health. And my one goal for the one slide I have on promoting brain health is that anybody who sees that slide or listens to this webinar will take that and just give that page to everybody they know, because regardless of where you are in the lifespan, if you do those things for your brain, they're going to help your brain. Just like we talk about heart health, let's talk about brain health. So just spread the word. And then I'll tell you about what we call the GSA KAER, or KAER framework. We'll talk about the benefits of that framework. And then throughout the rest of the presentation, I'll show you kind of the steps of that original KAER framework and this original KAER Brain Health Toolkit, or KAER Toolkit for primary care teams. And then we'll look at this new resource that, again, has roots in Ohio, and that's the Addressing Brain Health in Adults with Intellectual and Developmental Disabilities. And it really is meant to be a companion to our toolkit. I expect that we'll have a good amount of time for questions and discussion at the end. And so let's start with just looking at what are signs of dementia and kind of comparing those with typical age-related changes. If someone has dementia or Alzheimer's, they're going to have memory loss, but they're going to be more likely to be forgetting recently learned information. So their long memory might be very solid, but they also will begin to have sticky notes there, or electronic memory aids. Things either suddenly, or perhaps not suddenly, gradually, increased reliance on those things, and often we'll have the same question repeatedly. That's going to be different than what we all do, which is occasionally forget an appointment, then go, oh my gosh, I had an appointment this morning, I completely forgot. So we're going to forget something, a name, an appointment or something, but we remember it later. And that's really that typical age-related change. If someone again with dementia might have trouble remembering familiar things, making a grocery list, remembering how to play a favorite game, remembering routines that are very familiar, versus some of us who get something brand new and we need help setting it up. We know the directions are there, but we prefer to call somebody to give us a hand to help with that. Someone with dementia may have difficulty planning or problem solving, so they have trouble managing money. They can't follow a recipe that they perhaps had followed. One of my dear friends' mom now has very advanced Alzheimer's, but early in Alzheimer's, she could really follow. She was a Italian mom who had made beautiful homemade things for her family for their entire life. And she was still making homemade pasta to pretty late in her Alzheimer's association, because it wasn't even a recipe. It was just something, it was a familiar routine to her. She was able to do that pretty far into the trajectory of her disease. But very often people can't play a game or, again, follow a budget, a recipe, something along those lines. Versus someone who occasionally makes an error on the bill, adds it in your checkbook rather than subtracts it. That's somebody's always, all of us have done that. Confusion with time or place, so losing track of the season. Perhaps we're inappropriately dressed for the season or the time of year, forgetting how they got somewhere. Versus very normal, forget what day it is, but we remember later on, or can use a cue to remember. Being unable to, problems with words or speaking. We can't remember, maybe can't take part in, can't get engaged in a conversation or continue to engage in that conversation. Or we can't name familiar objects. This thing on my wrist that tells me the time, but I can't remember the name of the watch. Versus we sometimes can't remember what word to use, and you go, you know what I mean, hon, that thing we were just talking about. The visual images or spatial relationships. The older adults with dementia may begin to fall more. They may be something classic I would see in the nursing home. If there was a dark spot on the floor, we would see folks trying to step over that floor, that spot, if they had dementia, almost like it was a hole. Sometimes individuals would go to get in their closet. They'd fall into their closet. They just didn't have that depth perception. Versus visual changes, a loss of ability to see close up. I recently am more and more dependent on my bifocals than I was several years ago. Very normal change. Decreased judgment. Folks that may be, folks that have Alzheimer's may be taken advantage of in a scam. They may have trouble managing their money. They are usually very, very well groomed, and now you're seeing the same clothes on for a couple days, or not wanting to bathe, versus occasionally making a bad decision. We have the example here, neglecting to change the car oil, or that occasional Saturday where you wear your jammies until it's time to take a shower and put on clean jammies. We've all done that, right? That's an occasional bad decision. And then we see individuals with Alzheimer's who withdraw from work or social activities. We have a podcast that I had the opportunity to talk to a lady, Maureen, with a husband named Angus, who she described as going in and working the room and really being the social butterfly and just pulling everybody together and loving the game of golf. And as his Alzheimer's progressed, she saw those abilities to really engage in those social activities that he loved just kind of dwindle away. And then we compare it with a typical age-related changes of sometime not wanting to attend a family or social obligation. My husband has a brown shirt with the brown M&M on it that says, "Sorry, I'm late. I didn't want to come," right? We all have an occasional family event that we feel like that about. And then finally, I'll mention changes in mood and personality. So becoming suspicious, anxious, or afraid, maybe seeing a shadow or something outside the window and thinking there's someone outside my house. Versus as we become older and are become a little more sometimes used to a particular routine, and may become irritable when it's disrupted. So we want to have our usual routine, want to have a breakfast, our usual time of day, want to get up and do our thing. And that's really normal aging. That's normal everyday life to me. So how do we keep our brains healthy? The first, there's 10 habits here that I'll share with you. And the first is breaking a sweat. So really engaging in regular cardiovascular exercise, things that actually elevate the heart rate, increase the blood flow to the brain. There really is an association between physical activity. Study after study shows that, and reduced risk of cognitive decline. And then hitting the books. So really formal education at any stage of life will help reduce your risk. So this isn't just mind games, crossword puzzles, things. This is actually a formal education. And we do know that one's educational level is really correlated with their likelihood of dementia. But we also know one's education level has a lot to do with a lot of other things, right? Like the ability to pay for college and having a safe environment and food security and all of those things, which probably also, so we can't really tease all those things out, but we do know that formal education makes a difference. We also know that challenging and activating your mind, so whether it's doing puzzles, being artistic, playing games. I always think as I'm wasting time doing the Wordle, especially if I'm catching up on a few of them, that I'm helping my brain. I'm not just wasting time on the Wordle. Quitting smoking. So we know that quitting smoking can actually reduce the risk comparative to those who have never smoked. So this is one disease that really quitting smoking can have a pretty profound effect. And then following your heart, keeping an eye on things like blood pressure, obesity, diabetes, things that really raise the risk for cardiovascular diseases and stroke. And again, taking care of your heart, and maybe your brain will follow. And then keeping the head or brain safe. And so things like using a helmet when playing contact sports or riding a bike, taking actions to prevent falls, wearing a seatbelt. So just being mindful of protecting the head. And eating healthy. More and more we talk about healthy diets, and there's some discussion about Mediterranean diet or the DASH, or the dietary approaches to stop hypertension, or kind of a combination of those two diets that are really considered to be brain healthy diets that may contribute to reducing risk of dementia. And then sleep, getting enough sleep, or things like sleep apnea, not getting enough sleep, or things like sleep apnea, other problems may again result in problems with memory or thinking. And then taking care of mental health, looking at things like people with a history of depression that may have an increased risk of cognitive decline. Similarly, signs and symptoms of anxiety or other mental health concerns may contribute to cognitive decline, and certainly managing stress overall. And then finally, staying socially engaged. We know, and I think we saw this in COVID so very profoundly, how much social isolation really negatively impacted people. So whether it's you want to volunteer at an animal shelter, sing in a chorus, just connect with people, how very important that is to take care of your brain. So those are 10 pretty easy things that we often talk about for keeping our heart healthy for some of them, but remembering that our brain health is equally, or perhaps even more important. And then making most of our time together today. I welcome you to either go to geron.org brain health, or scan the QR code, or take a look afterward. But I want to mention to you that anytime now, we will actually be launching a brand new KAER Toolkit. So right now, if you go to this website, the first thing you'll see is it's called the KAER Toolkit for Primary Care Teams. And it is a toolkit that is exactly what it sounds like, intended for primary care teams. That's all about helping them to take steps to improve brain health care for people. Well, what we've done, that was our second version that's currently on our website. We have built that into a microsite of the GSA website. So we now have a fully online KAER Toolkit with beautiful graphics, and it's all interactive, and it links to all different stuff. So if you check back probably next week, you'll actually see the updated KAER Toolkit. The good news is the information I'm showing you tonight remains in that toolkit. We've just added even more stuff into it. So the framework is still the framework, and the ideas in the toolkit are still the same ideas. And what we're really focusing on here tonight is that IDDD companion, which has not changed at all. So I already told you a little bit about GSA. We are a professional society. We have about 5,500 members, and really we focus on really 4 main areas. We have researchers, we have people who are actually caregivers, people who are very involved in advocacy, and GSA is involved in advocacy for meaningful policies that address meaningful lives, advance meaningful lives as we age. Some examples of how we advocate in policies is GSA was very involved in helping secure coverage for adult vaccines that are recommended by the CDC. We're very engaged in helping get Medicare coverage for oral care issues that were linked to cancers. Things along those lines are the kind of things that GSA advocates for. And then we certainly have a huge amount of educators, people who work in academia in our membership. And so where did this whole care journey start? In 2013, the Centers for Medicare and Medicaid Services approached GSA and said basically the annual wellness visit, the Medicare benefit, the annual wellness visit wasn't being used. And a big part of that is how older adults who are at risk for or actually have signs or symptoms of dementia are inadequately assessed by their primary care providers. So a big part of the annual wellness visit is screening for cognitive impairment, and it just wasn't happening. So GSA pulled together a work group, and then in 2015 published the report that's shown on the left. And then from that, in 2017, the first KAER Toolkit for brain health was launched, and then that was updated in 2022, or I'm sorry, 2020. In 2022, GSA launched a KAER Toolkit for obesity. And if you think about the conditions for an older adult with cognitive impairment or an older adult with obesity, there's a lot of similarities. Nobody wants to talk about it, neither the patient or the physician, or the provider, I should say, not the physician. There's a lot of stigma around both conditions. There's a lot of, oh, if I'd done something different, I wouldn't be in this position. And honestly, for both brain health and obesity, there's a lot of throw my hands up if I'm a provider and say, why bother? What am I going to do about it anyway? The KAER Toolkit really sought, the brain health KAER Toolkit sought to answer that. What am I going to do anyway? Wrap people in supports and services in the community, and they'll do better longer in the place in which they want to live. And then in the KAER Toolkit for obesity, we really use this evidence-based approach to a full continuum of evidence-based care provided by an interdisciplinary team. So a lot of similarities, and we're really proud of both of those toolkits. And then in 2013, I heard from one of my colleagues, a GSA member who is a nurse practitioner who's worked with people with developmental disabilities since the 80s. And she shared with me a story. And that story was that a patient that and actually that story is in this KAER Toolkit companion, a little excerpt of it. A patient that she took care of in the community had moved from a large, more institutional setting to a community setting, like a smaller group home setting. The individual lived in that large institutional setting for quite a long time, if not their whole life. They were in their 60s. And when they moved to the group home, they had a lot of changes. They weren't functioning quite as well as they were in that prior setting. Their cognition seemed to be changing. And so they made a call to the primary care provider's office, and they were diagnosed with dementia over the phone. And Kathy, my nurse practitioner friend, actually ended up going to see this patient. And what he had was profound dementia, or I'm sorry, profound depression. What we all would think of, oh, isn't that a better change of life? He's in a smaller home, it's a community setting, isn't that wonderful? But all his friends were at that large place. That large place was all that man ever knew. When they treated his depression, magically his cognition improved. So the nurse in me said, how can anybody be diagnosed over the phone with dementia? We have to do something different. And that's where the KAER Toolkit for the KAER Toolkit companion for the intellectual and developmental people with intellectual and developmental disabilities was born. And Kathy Service is that nurse, and she, I think, has trained some there with the NTG in Ohio, and she was one of our panelists on this. So I owe Kathy a great deal of debt for sharing her stories and her passion with me. And so what does KAER stand for? It is Kickstart the Brain Health Conversation, Assess for Cognitive Impairment, Evaluate for Dementia, and Refer for Community Resources. And the KAER Toolkit is intended as the supportive document of practical approaches, educational resources, validated clinical tools to really help primary care teams and others implement better care around brain health in their practices. Most of the stuff in the GSA toolkits is not GSA's stuff. It's all of the stuff that's out there in the literature and the evidence evidence-based tools, and we work with an expert work group to really help inform us as to what's the best of the best that should be included in this. So currently there is, it is an electronic format with tabs. Again, it's going to be a new web-based format. It will still have tabs for KAER. There will still be tabs to each section, except now they're colored pictures on a carousel. There's still key section takeaways for each section. We talk about how people can get paid for care-based care, information on communicating with older adults. Again, we highlight the best of the best, and there are lots of other resources that really branch off from these main toolkits. And what's the new exciting story is this toolkit companion addressing brain health in adults with intellectual and developmental disabilities. And again, it's intended to be a companion. So to address the needs of adults with IDD who develop dementia and who are at risk for dementia, really the goal here is to raise awareness of the unique needs of adults living with IDD. And we stress in here that we want individuals to be having brain health providers, community support workers, whoever it might be, to be having appropriate brain health conversations in adults with intellectual and developmental disabilities. We want to stress that even if there's a very high chance that someone will develop dementia or Alzheimer's, that there's still things people can do to help their brain be as healthy as it can be. So we want to take away that idea that it's inevitable and why bother doing something healthy for your brain. We want to promote those brain health conversations and really promote the idea of detecting changes early and looking at those being in changes in cognition as well as adaptive functioning. And then really assist in identification of community supports aimed at enhancing function and quality of life for adults with dementia and IDD. One of the coolest things that's happened as a result of these trainings is I get to see people in different counties come together. Some might be from aging services and some will be from the Office of Developmental Disabilities. Never have they come together for one training. And it blows my mind to be able to see them come together to say, wow, we might actually be servicing the same person. So how can we really, learn together to leverage, make the most of the limited resources that are available. One of my colleagues is actually working on a project to look at technology for caring for older adults in the home. And I say to her, look to the community who takes care of people with intellectual and developmental disabilities, because you guys use technology a lot better than we do in aging services. So we have a lot to learn in that space from all of you. I'm actually connecting her with some folks in Ohio that can help make those inroads to learn about, like you guys in Ohio have a really innovative like telerespite thing where someone can monitor like 10 people's homes at once for an hour or two while a family member runs to the grocery store. That doesn't happen in aging services, but it's really cool stuff that's happening in developmental and disability space. And so we do have, in our overview section, we actually have a summary of dementia characteristics in people with neuroatypical conditions. So if there's this particular condition, what is the risk for dementia? Is it higher or lower than the general population? And then if they do have dementia, what's the most likely type of that? What are some risk features about that? What might cause that or be causing or contributing factors? And then what are other associated features? So this can be really helpful to understand an individual's risk across their lifetime of developing dementia. And so let's turn now to that first step of the KAER framework, and that is the K, the kickstart. And in this first section, it's all about kickstarting the brain health conversation. When providers discuss brain health, they and their teams observe for signs and symptoms of cognitive impairment, and they listen for patient and family concerns. And again, this section, the tools and resources are all about really these three main bullets. But what are our approaches to implement? We look at certainly addressing sensory loss and applying effective communication. And you'll see examples in the kits of like key messages around brain health. So really raising that topic and continuing the conversation. Asking about memory and cognition and really listening for concerns. There's a great video of Dr. Josh Chodosh that comes from the Alzheimer's Association that's having conversations about memories and concern. We're listening to family concerns and then looking for those signs and symptoms. Maybe the individual's missing their doctor's appointments. Maybe they're not taking their medication. They haven't yet filled that new prescription. So what's going on with that? Then consider asking a memory or cognition question, and then using electronic health records to flag potential indicators. So what else is going on? And this is just an example here of key messages about brain health. So again, cognitive aging, we talk about that it's not a disease, it's a lifelong process. And some cognitive functions actually improve with age. We also have a lot of what we call momentum discussion podcasts. And if you click on this link, it will be live in the slides that I sent you. We'll bring you to all of them. And that is where the one, you can find the one we discussed earlier that addresses the hearing loss and cognition. And then again, just some other tools and resources. We offer a lot for patients. And what do we do in this new Kickstart Companion? When we're really using here, stressing the need for healthcare providers to use strategies and language that the individual is able to comprehend, and stressing that we need to incorporate caregivers in the conversations. And we do talk a lot about this idea of establishing baseline cognitive and functional status and really looking at that over time by compiling a life story. So we talk about whether it's a cell phone video or whatever it might be to really identify the functioning and the life story of that individual. And certainly using person first language, GSA is all about that regardless of what we're talking about. We certainly don't talk about diabetics or obese people. We talk about people with diabetes or people with obesity. Similarly, we're going to talk about person first language when we're talking about someone who has an intellectual or developmental disability. An assess for cognitive impairment is all about using a validated brief cognitive test, determining if further evaluation for dementia is needed. And I always say it's not possible. It's not only possible for the whole team, so beyond the medical provider, to participate in these activities. It's really essential. So it is really a team sport. And so in the assess section of the KAER Toolkit, we look at using validated brief cognitive tests for the individual, for them to give their own perceptions, and for families to give perceptions. And again, having office staff participate. We have some great case examples where medical assistants in a provider's office are doing these cognitive screenings. And actually, there's a rock star group up at the Cleveland Clinic who have gotten up to doing 5,000 cognitive screens a month. Their medical assistants are doing them, and that is an incredible number. I mean, kudos to them. They're doing amazing work up there. So good stuff happening all around in Ohio. And so we do have the brief cognitive tests, and many of these are for the general population, and many are available in languages other than English. And similarly, there are tools for, again, family and informants and self-report. The problem is that these aren't adapted at all for use in the population of people, with intellectual or developmental disabilities. So what do we do in this new assess concepts, the new assess concepts in the companion? First and foremost, avoid interpreting the manifestations of new impairment as suddenly an underlying, an extension of their disability. So this kind of diagnostic overshadowing, or, oh, they're just getting older and they have this disability, that must be what it is. But we also, if it is possible to use a mainstream tool, they may need to be adapted to accommodate for sensory impairments. We had already talked about this idea of having longitudinal assessments, but more importantly, we're looking at cognitive screening tools that are specifically developed for individuals with intellectual or developmental disabilities. One of those is the NTG EDSSD, and that is the NTG's early detection screen for dementia. We did collaborate with the NTG, the National Task Group on Intellectual Disabilities and Dementia, on this KAER Toolkit. They were another one of our collaborators. And then again, capturing that history. So what's the living situation, level of functioning, key changes, events in their life and things along that line. So we do have here, based on the different conditions, what might be the best approach for assessing cognition. So the frequency, what are some certain measures that can be used? How can things be adapted? What are barriers to those assessments? And should informants be used? And then as we evaluate dementia, here's where we're really highlighting how important a diagnostic evaluation is. Dementia is a diagnosis very often of exclusion. So really taking a look at all other things and saying it's not that. So we've confirmed it is dementia. And then again, the primary care conducting or referring for that diagnostic evaluation. And in the KAER Toolkit, this one of my favorite pieces, I would say, in the whole KAER Toolkit is where we lay out a table of 8 areas that are really components of a diagnostic evaluation. So after we're able to support the individuals and their family members in understanding why this is important, so getting over that why bother anyways, there's nothing I can do attitude, to say this is important because we can do things to make your brain healthy. You might even be appropriate for one of the new disease modifying treatments or a study that's going on or something along those lines. And then we conduct that evaluation again with the recommended components, looking at physical exam, blood work, lots of different recommendations in there. And then if possible, making a differential diagnosis. So what is actually the type of diagnosis? And then disclosing that. There's some really great videos and things about disclosing a diagnosis to the individual. And then when indicated, also disclose to a family or trusted friend. And there, again, this is just a snapshot of the components of the diagnostic evaluation. I do want to also mention that GSA has some really great work on some other conditions. One of my very favorites is the agitation and Alzheimer's disease that's listed here. This really offers some really great strategies about managing behaviors in general. So if folks might be able to use that, again, all of this stuff is free and available online. So I welcome you to share it with colleagues and to just direct them to this stuff if it can help in any way. And then we do have some evaluate tools and resources that are linked to other associations and other organizations that can help with different types of dementia. So whether it's Alzheimer's, vascular, Lewy body dementia, and then again, the resources on how to disclose that information. And then so what about the new evaluate concepts? I mentioned before that dementia really is often a diagnosis of exclusion. So when the assessment identifies that there is some change in that cognition or adaptive functioning in the adult with IDDD, that a thorough evaluation to determine whether it is a diagnosis is appropriate. And then I already mentioned that issue of diagnostic overshadowing. So how important it is to avoid that, avoid us saying it's attributed to that pre-existing disability, rather than identifying any number of factors that could cause this. And just some of those, I mentioned medication adverse events, thyroid changes, nutritional changes, vision or hearing impairments. I gave the example before of that disruptive life event. So lots of things that could cause this. So really the care team's job here is to identify conditions that might be amenable to treatment, that we could actually reverse those declines, mitigate symptoms, and improve quality of life. And again, conducting that thorough evaluation, because I'm considering a range of issues. And we do in here say, well, what are some of those things we can evaluate for? And so we list a bunch of conditions like sensory issues, pharmacological concerns, seizures, pain, and then list how might that present. So we look at mobility problems, loss of functioning, mobility disorders, conditions that may be associated with cognitive deficit, like maybe they've had an injury or a bump in their head, something along those lines. So and then there's additional considerations. So it's just kind of a laundry list of saying, did you think of this? And then we do list the components of an evaluation. So looking very similar to those components that we list in the main KAER Toolkit, pertinent medical and psychiatric history, historical description of baseline functioning, description of current functioning with comparison with baseline, the focused review of symptoms, the review of medications, and certainly keyed up on polypharmacy, family history, the psychosocial issues or changes, and then again, social history, living environment, and level of support. So we list those components and then say, what are some details along those lines that we can take a look at? And then this table, I think, is one of the most useful in the whole toolkit. And this actually lists the screening tool, gives a description of the tool, and lists some strengths and weaknesses of each of these tools. So dementia questionnaire for people with learning disabilities, dementia scale for Down syndrome. So lots of different, and this is just a little excerpt of this giant table of all this. So it really gives some great insights into what are strengths and weaknesses, what are these tools all about? And then again, many of them are available, freely. And then finally we get to refer, and this is that fourth step that says, why bother getting a diagnosis? What am I going to do anyway? And this is where it's at. It's all about referring to internal staff and community agencies that can provide ongoing support, education, referrals to other services, and certainly encouraging participation in clinical trials. And here I think it's really important to mention, whether it's the general population or it's an individual with an intellectual or developmental disability, the acceptance and willingness to engage with education, with supports, with referrals varies greatly over time. I have a neighbor down the road, 3 houses down the road, who is a nurse, whose mom has very profound dementia at this point. And his dad will finally accept some help. But for years, he was not going to talk to the nurse who's engaged with the Alzheimer's Association. He did not need any help. Everything was fine. She was fine. But eventually the acceptance will change over time. And so I think it's important that as clinicians, we're sharing with people what may happen down the road. We don't want to paint a picture of doom and gloom, but we want to be a little bit realistic of, you may need some help with this in the future, and we can help provide you with that support. We'd love to tell you more about it now, but if you're not ready, we'll be here when you are. And then so our approaches to implement here are all about referring to internal staff or community agencies and conducting that regular follow-up, and again, encouraging participation in clinical trials. And more, there's so many clinical trials that are available. There is something called Trial Match from the Alzheimer's Association that anybody, regardless of their age and their health, can put their information in and find a trial that might be available even to any of us. Like there's healthy brain trials where people study, cognition over time and risk factors and all of that. So Trial Match is a pretty cool resource. We do have a resource, that's a referral form that GSA developed, and teams are welcome to take that and make it their own. And just, it kind of gives some ideas about who might help with certain things if someone has dementia. And one of my very favorite podcasts is the Momentum Discussion podcast called An Interdisciplinary Approach to Community Referrals. And this is starring my good friends, Carolyn Clevenger and Laura Metters down at Emory University. It's a nurse practitioner and a social worker. And they talk about the approach that their interdisciplinary team takes. And it's really a risk-based approach to low risk, high risk, medium risk. Where are you? We can't get there from here, or, steady state, or we're really in a crisis and we've got to do something immediately. So they really use this team approach, a risk-based approach, and it's a very, very insightful discussion. So if that interests you at all, take a listen. And so what do we do in this new refer concept, refer concepts in the companion? If a diagnosis is made, again, it's referring to resources in the community. And again, this is where I think we're looking at perhaps the ID or DD service agency may be expanding to other agencies in the state that might provide different levels of supports, maybe different things more appropriate for older adults, or and kind of the two can come together. I think it's so important to come together, and our resources are so slim. So how do we most judiciously use those resources to ensure that we meet the needs across different agencies? And again, sharing diagnosis when it's appropriate. And overwhelmingly, if we're using care approaches for the general population with dementia, we're going to adapt those for the individual with ID or DD and the dementia. And then again, conducting individualized care planning. So we do note some post-diagnostic supports. And what we note here is really in the post-diagnostic stage. So it's maybe immediately after diagnosis or on an ongoing basis, or perhaps when somebody is more in advanced stages of dementia. And then we also address here strategies for managing adults, dementia in adults with IDD. And so we're really looking at, again, these kind of pre-diagnosis phase, the actual time their diagnosis, and then post-diagnostic. And what are we doing where we're looking at, like in the example here, pre-diagnosis, screening for warning signs, you know, assessment indicates symptoms aren't related to dementia. Well, what do you do with that? So these are all really about kind of the boots on the ground actions to help individuals who have been diagnosed if they are an adult with ID or DD. And I do want to just again acknowledge our collaborators, the NTG, the Ohio Council for Cognitive Health, and the Ohio Association of County Boards of Developmental Disability. There's no way we could have done this without these experts from all of these organizations sat on our advisory panel and gave us tremendous insights and case studies, and quite frankly, an awful lot of passion to get this work done. It's really, we're very, very grateful to them. And we are grateful ASI did support this toolkit. They allowed us gave us the funding to allow this to happen. So we're really grateful to them. And I want to close with just sharing my email. I welcome questions and inquiries about this. And I am going to stop sharing if I can figure out how to do that. And just invite any questions. And most of all, thank you, Laura, for inviting me to spend some time with you all.
Oh, thank you. This was wonderful. I'm going to stop recording now so people can feel free to ask questions and know
Great.
that their information is not going to be posted anywhere.
Great.